Pleasure to be here. Thanks for the invitation. I wanted to share with you some of my experience about treating patients with dizziness and vertigo, as well as hearing problems, in order to treat our patients in a better way, so they can. So they can get all the help we can provide them. We have to understand that vertigo and dizziness are symptoms. They are not diagnosis. We have to ask the patient to have an accurate clinical history in order to have an correct diagnosis and a treatment to the patient. Also, it's important to consider that each patient has may have a lot of problems or diseases that might increase their symptoms, that might make them to feel more uncomfortable or more dizzy. And we have to understand that the patient is personal, it's individual, and we have to treat it that way. The patient also, when we were talking about vestibular rehabilitation, it has to be personalized. We cannot do it like cooking a cook recipe. It has to be individualized with what the patient is suffering or what the patient needs to work with. We need also to have to know their expectations of the patient in order to tell the patient if we can really help him, or to have these expectations, have real expectations. What else? I'm just like talking, and I don't know what else to tell you. We need to work as a team: otorhinolaryngologists, ear, nose, and throat MDs, neurologists, first practitioners, and we need to work together, because the patient usually does not arrive at the first time to us. The otorhinolaryngologist usually goes to the prime physician, and then sometimes to the ear, nose, and throat doctor. And sometimes when they come to us, they have gone to a lot of medical doctors before, and we are a team. We don't have to forget that we're focused on the health of the patient, not egos. Also, and to work as a team, to have your neurologist of your trust, also a psychiatrist, because as we know, patients with vertigo and dizziness have a lot of anxiety, and sometimes they are anxious and get more anxious with a vertigo or dizziness, and sometimes even though they didn't have a history of anxiety, when they experience an attack, they will feel anxious. So we need to listen to them. We have to analyze if we need to make some complementary studies, as audiometry, low audiometry or speech test, tympanometry, video nystagmography, and ocular movements, head impulse test. So, because there are some things we usually, some words. What else? If there is a patient who has a hearing problem, it might be mild, moderate, severe, profound, and it can affect low pitches, middle pitches, or high frequency, high pitches, or all of them. Hearing is not black or white. Hearing is sometimes the patient might have mild, as I told you, mild hearing loss, or moderate, severe, or profound hearing loss. And also we have to check how is the outer ear, middle ear, and inner ear. We have to remember that in order to have another balance, equilibrium, we need eyes, we need inner ear, and we need also proprioception. And the director of the orchestra is the cerebellum. Okay, so we need to focus on that, and to see how the flocculus it's working. Sometimes, usually, the flocculus is the one that it's affected in the cerebellum. Also, we have to consider if we need some MRI, some
finish time.
Yeah,